How does health insurance work? Imagine you have a $100,000 heart surgery, which is a covered medical expense under your health insurance plan. And let's say this health insurance plan has a $1,000 annual deductible, 20% coinsurance after deductible, a $2,000 out-of-pocket limit, and a $2 million annual limit on your health insurance coverage. In this video, we'll explain how these different components of a health insurance policy work. Before we begin, it's important to note that any health insurance policy purchased after September 23, 2010 will not have a lifetime maximum limit on most of the plan benefits. And any health insurance policy purchased after January 1, 2014 will not have an annual limit on most plan benefits. The first thing we'll talk about in this video is a deductible. What is a deductible? Typically, a deductible is the amount of money you must pay each year before your health insurance plan starts to pay for covered medical expenses. So, with a $100,000 heart surgery bill, you are responsible for paying the first $1,000. After this $1,000 deductible is met, the insurance company will pay a percentage of the bill and you will pay the coinsurance. Let's talk about coinsurance. What is coinsurance? Typically, coinsurance is a cost-sharing requirement where you are responsible for paying a certain percentage and the insurance company will pay the remaining percentage of the covered medical expenses after your deductible is met. For a health insurance plan with 20% coinsurance, once the deductible is met, the insurance company will pay 80% of the covered expenses while you pay the remaining 20% until your out-of-pocket limit is reached for the year. What is an out-of-pocket limit? Typically, the out-of-pocket limit is a maximum amount you will pay out of your own pocket for covered medical expenses in a given year. For a plan with a $2,000 out-of-pocket limit, you will pay a $1,000 deductible and $1,000 coinsurance, while the insurance company covers the remaining $98,000 of the heart surgery bill. Even if you're hospitalized again in the same year, the insurance company will pay 100% of your covered expenses until you reach your annual coverage limit. What is an annual coverage limit? Some health insurance plans place dollar limits upon the claims an insurance company will pay over the course of a plan year. So if you bought an insurance policy with an effective date of July 2011, your plan year would run from July 2011 until June 2012. If you have an annual coverage limit of $2 million and you have medical bills that cost more than $2 million during your plan year, you would be responsible for paying those bills out of your own pocket. Once your new plan year begins in July 2012, your deductible, coinsurance, out-of-pocket limit, and annual coverage limits would all reset, and the insurance company would once again begin to pay your covered claims. Beginning September 23, 2010, the Patient Protection and Affordable Care Act, Healthcare Reform, begins to phase out annual dollar limits. Starting on September 23, 2012, annual limits on health insurance plans must be at least $2 million. By 2014, no new health insurance plan will be permitted to have an annual dollar limit on most covered benefits. Some health insurance plans purchased before March 23, 2010 have what is called grandfathered status. Health insurance plans with grandfathered status are exempt from several changes required by healthcare reform, including this phase out of annual limits on health coverage. Here's one more concept you should be familiar with. Some health insurance plans offer co-payments. What is a co-payment? Typically, a co-payment or copay is a specific flat fee you pay for each medical service, such as $30 for an office visit. After the $30 copay, the insurance company pays the remainder of the covered medical charges, sometimes subject to the deductible and coinsurance. Certain recommended preventive services, immunizations, and screenings are covered with no cost sharing or co-payments on health insurance plans purchased after March 23, 2010. Let's say you're not feeling well and went to see your doctor who charges $200 for the office visit. If your insurance plan has an office visit co-payment of $30, then you will only be responsible for the $30 and the insurance company will cover the remaining $170. But if you purchased your health insurance policy after March 23, 2010, and you're due for a routine preventive care screening like a mammogram or a colonoscopy, you may be able to receive that screening without making a copayment. You can talk to your insurer or your licensed e-health insurance agent if you need help determining whether or not you qualify for screening without a copay. There are 5 important changes that occurred with individual and family health insurance policies on September 23, 2010. Those changes are: added protection from rate increases. Insurance companies will need to publicly disclose any rate increases and provide justification before raising your monthly premiums. Added protection from having insurance canceled. An insurance company cannot cancel your policy except in cases of intentional misrepresentations or fraud. Coverage for preventive care. Certain recommended preventive services, immunizations, and screenings will be covered with no cost sharing requirement. No lifetime maximums on health coverage. No lifetime limits on the dollar value of those health benefits deemed to be essential by the Department of Health and Human Services. No pre-existing condition exclusions for children. If you have children under the age of 19 with pre-existing medical conditions, their application for health insurance cannot be declined due to a pre-existing medical condition. In some states, a child may need to wait for the state's open enrollment period before their application can be approved. If you have questions that were not covered by this video, please contact a licensed e-health insurance agent at 1-800-977-8860.
Welcome to the Real News Network. I'm Paul Jay in Baltimore. We're now into the beginnings of the implementation of what everybody, including President Obama, is calling Obamacare. So now we have a little better idea of what it is and how it might work. Now joining us to talk about it are 2 critics of Obamacare. First of all, Kevin Zeese is co-director of It's Our Economy, an organization that advocates for democratizing the economy. And also joining us is Dr. Margaret Flowers. She's a pediatrician from Baltimore who advocates for a national single-payer health care system, or Medicare for all. Thanks for joining us.
Thank you for having us.
So tell us now you've been critical about this from the beginning. You were for single payer during the health care debate.
Right.
But now it's passed, it's starting to be implemented. You have a better idea what it is, so how's it looking?
Right, well, it's looking pretty much like what we expected. Right now, the United States is the only industrialized, wealthy nation that has a market-based healthcare system, and the Affordable Care Act moved us further in the direction of a market-based healthcare system by requiring people who don't qualify for the public programs to purchase private health insurance. That will be going into effect. The exchanges where people will buy that insurance roll out in October of this year. By January 2014, people have to have insurance or face a penalty. But what we're seeing in terms of the type of insurance that people are going to be offered and the trends of what people are actually purchasing right now is we're moving more in the direction of what we call underinsurance, where people may have an insurance plan, but there are significant financial barriers to getting actual care and significant financial risks if someone has a serious accident or illness. Well, so if, what we see, it's interesting, over the last 3 years, there's been a slowing in the rate of rise of our healthcare spending in this country. And it was interesting because the president said in the State of the Union address, oh, the Affordable Care Act is already working. We're seeing our costs slowing. But the actual data shows that our costs are slowing because people are using less health services. The copays and the deductibles that they face mean that they don't have the cash in their hand to go and get those healthcare services. And then what we're seeing in terms of bankruptcy, and this is actually based on a study done before the economic crash, based on 2007 data, was that 62% of our personal bankruptcies were due to medical costs and illness. Almost 80% of those patients had some form of health insurance. If we look at Massachusetts, that's had the same kind of legislation on the state level, the number of medical bankruptcies there is actually rising.
And so why is that? If you have health insurance, why are you going bankrupt?
Because they don't cover, they have co-insurances, so at some level, they cover up to this level, but after that, your co-insurance is 20%, so you have to pay for 20% of the services. They can say that services are uncovered services, and so then you're liable for those. They can restrict the networks. So an interesting, out in California, Blue Cross Blue Shield out there that covers the largest number of public employees, dropped Cedars-Sinai and UCLA from their network because that's where people go when they need actual health care. So if you have a serious problem and that's the place that can treat you, you're going to have to hold a bake sale or sell your home or do something so that you can afford that care.
Now, Obamacare make this worse because what Obamacare does is there's several levels of insurance coverage. 90-10, where the insurance company pays 90%, consumer pays 10%, 80-20, 70-30, 60-40. The subsidy provided by Obamacare to people who can't afford insurance will only cover 70-30 plans. So when you get a serious illness, you're paying 30% of the cost of that health care. Now, what's really bad about this is that prior to Obamacare, some of the state insurance regulators were pushing insurance coverage to a higher level, where they would provide more coverage rather than less. Obamacare has now put into law that 60-40 is okay, and 70-30 is what the government will pay for. And so the 80-20 and 90-10s have become less common, so you're going to see more and more people with underinsurance. And not going to see lack of insurance completely go away. In Massachusetts, which is basically the pilot program for Obamacare, Romney Care was the pilot for Obamacare, it's pretty much the same plan. What you see up there is only about half of those people who are without insurance got covered by Romney Care. The same is going to happen here. The Congressional Budget Office is estimating 30 million or more people will have no insurance when Obamacare is fully implemented. But those who have insurance are now becoming with underinsurance.
And this is all kind of new to me. I mean, viewers of The Real News probably know I'm a dual citizen, and I was in Canada until recently, and we don't have any of this, right? It's
Right.
single,
You have a sensible program.
You have a government health care plan. When you're born, you get a health card, you show it, and that's kind of the end of it.
Right.
So now that I have not seen this before, the insurance I have down here now, I have a copay, but there's I think it's like a $3,000 cap. After that, the insurance pays 100%.
Of covered services.
Yeah, but it's,
If they say something's not covered.
okay, but are you saying that some of this, that copay does not have a cap?
It's not that the copay doesn't have a cap, it's what the insurance companies are able to determine. You know, they'll say that something is not covered, that it's experimental, or we see this all the time where they actually charge people for things that are in their plan that they shouldn't be paying for. And if you're not savvy enough to understand that your plan covers that service and then fight for it, before 2005, I think, looking at our Blue Cross program here. And what they found was that about 1 out of every 5 claims was denied just randomly. Like at 5 claims come in, they just pull one out and say, we're not paying this one. And it wasn't based on any rationality. It was just a way of being able to get more money. And we have evidence of this in New York from people that worked in these claims offices, that if there was a certain level area of the city, lower income area, they would deny those claims because they knew people didn't have the resources to fight back.
Go back to my example.
Yeah.
We had, I think it's an 80-20, so our copay
It's good coverage in the United States.
wasn't so terrible.
Right.
But I mean, the final bill had to be in the realm of close to $300,000. If it had been a 60-40, we would have been toast.
Yeah,
exactly
yeah.
right.
And then and the other thing with that is if your babies were born in December and you met that whole, what your out-of-pocket costs were in December and January, you start all over again, and that's where some families just can't handle that.
And that's what they're finding. That's what they're finding in Massachusetts. Is they're finding that with Romney Care, which was, as I said, the pilot program for Obamacare, they're seeing that people are not going to get health care when they need it because they know when they go, it's coming out of their pocket, and that's not a good thing. When you put off the necessary health care, what that results in is a bigger bill later. If someone's having a worse outcome, or
You can't work because you're.
Yeah, so it gets
you're
more
disabled
costly
now.
by not taking care of the problem at the initial stage. You let it grow and get bigger until you have no choice but to face it. And so in Massachusetts, they're finding bankruptcies are continuing at the same level. They're finding only half the people that were uncovered are now covered, and they're finding those who are covered are not getting health care that they need. That's not the kind of healthcare system we should have in the United States. It's not appropriate.
Where are we at with this then in terms of the politics of this? Is there any chance this debate gets reopened in the next 2-3 years?
That's really up to the people, whether we force it to be opened or not. I mean, it's interesting right now that you have, more kind of these articles coming out in Time Magazine looking at our healthcare system, and I'm not really sure what's behind that right now, unless they're trying to maybe win the argument by creating it early and not allowing us to make that argument. But I think what we're going to see over the next couple of years is we're going to see continued rise in our healthcare costs, continued poor health outcomes, families continuing to face financial barriers to care and bankruptcy. And it's up to us to start saying that these things are not okay and that there is a real solution. We'd like to join the rest of the civilized world and have a publicly financed healthcare system.
And just to answer your question a little more, there are people in the country who are working on this.
Absolutely.
And more people are looking at it through the prism of human rights.
Right.
Healthcare is a human right. It's not a commodity. We don't want Wall Street healthcare. We want a human right-based healthcare. And there's a Maryland healthcare human rights campaign. There's Vermont has one. There's Oregon. There's Washington. They're all over, coming up all over the country. Because people who are looking at how Obamacare is so far being implemented are seeing premiums rise, healthcare use going down. They're seeing more problems, and they're seeing what happened in Massachusetts. And so people who are aware are organized and getting more organized. So there's ways to get involved in this and reopen this debate.
Are there, given how paralyzed national politics is on this issue, are there some local examples of where there's some other alternatives? I know in San Francisco, I believe, has essentially a single payer.
They have a restaurant
tax.
tax.
A restaurant tax that pays for that. Yeah.
That pays for health care for people in San Francisco. Vermont has pushed as far as you can so far toward a single payer system. They have a number of steps to get there, but they have a good grassroots campaign that's continuing to push.
So there may be some initiatives at a municipal state level that might make some breakthroughs there.
But this needs to be a national solution. I mean, really, you want to be able to travel throughout the United States and have health care coverage.
In San Francisco, you just leave the city and you've lost your coverage.
That's what I mean.
Right, and also, the thing that I often point out is that the United States is already spending more than enough for a universal, comprehensive, high-quality healthcare system. We spend 2.5 times what the average OECD nation, industrialized nation, spends per person on healthcare. So we have the money to do this, and we have the resources to do this, and it's really just up to us to demand that we have the kind of healthcare system that we need. And you can't get the cost savings. That was my point, was that you can't get the real cost savings unless you do this at a national level.
What I was laughing about, I was thinking about Congress. There's all this craziness about deficit. Healthcare is 18% of our GDP and going up. And you're not going to solve the deficit for the long term without solving healthcare. And that's not Medicare, it's the problem. That's not Medicaid. The problem is the big part of the system, which is the market-based system. Paul Ryan, in his idiocy, pushing toward privatization of Medicare, why he thinks having an insurance company making profit off of elderly people and their healthcare is going to lower costs is just absurd. It makes no sense. But that's the state of the Congress. And Obama's even talking about reforms of Medicare that'll make it weaker, in my view. He's done some good things. I think getting Medicare Advantage was a good move. Medicare Advantage is a nice name for private insurance, which was ripping off elderly people, is what it was really doing. It was not a good part of the elderly health care in our country. So he did some good things on challenging that. But what we're seeing in Congress is no sensible discussion on this issue. We're seeing them push in the wrong direction toward more privatization, more cost, higher percentage of our GDP, and more deficit, and less health care for American people.
But the answer is simple, and as long as the people understand what it is that we require, and we don't settle for anything less,
which is Medicare for all,
then we can push in that direction and do it.
Okay, thanks for joining us, Margaret.
Thank you.
Kevin.
Thank you.
And thank you for joining us on the Real News Network.